This case report sheds light on a diagnostic challenge between two rare conditions: statin-induced necrotizing autoimmune myopathy, SINAM, and antisynthetase syndrome, ASS. A 74-year-old male with a history of hypertension and dyslipidemia showed elevated transaminases during a routine follow-up. He's referred to hepatology clinic where there is a suspicion of drug-induced liver injury from statin use. His atorvastatin is discontinued and a liver biopsy is performed. Before the biopsy resulted, the patient developed myalgias and proximal muscle weakness, as well as persistently elevated transaminases and CK levels requiring hospitalization. On admission, he was found to have grade 3 out of 5 power to his proximal extremities. His lab findings included elevated creatine kinase and transaminases, as well as positive autoantibodies, namely ANA, anti-PL7, anti-OJ, and anti-HMG coenzyme A reductase. Liver biopsy showed no active hepatitis, and rheumatology recommended a muscle biopsy which revealed myonecrosis. These features pointed to both SINAM and ASS. His initial treatment included oral methylprednisolone, but his symptoms worsened and he was escalated to intravenous immunoglobulin and pulse steroids. Despite treatment, the patient's condition continued to deteriorate and his muscle weakness progressed, leading to respiratory failure, requiring intubation and mechanical ventilation. Unfortunately, after 1 month in hospital, he died from septic shock and multisystem organ failure. As shown in the table, this patient demonstrated features of both SINAM and ASS. To navigate this difficult diagnosis, we meticulously examined the diagnostic criteria for antisynthetase syndrome as outlined by Connors et al. And Solomon et al. These criteria emphasize clinical features such as interstitial lung disease, Mechanic's hands, arthritis, fever, and Raynaud's phenomenon. Despite the presence of ASS-associated antibodies, our patient did not fulfill these specific criteria. Additionally, the patient's disease progression was atypical and notably rapid for either ASS or SINAM. We also thoroughly reviewed the past medical record of the patient and realized that he had previously been on atorvastatin and it was discontinued after 1 month use about 10 years before because of myalgia and an elevated CK. These details and the fact that the patient had a positive anti-HMG coenzyme A antibody, which has greater than 90% sensitivity for SINAM, was more in keeping with that diagnosis. This case is unique because of the patient's lack of improvement despite statin discontinuation and treatment. It emphasizes the significance of monitoring statin users for myopathy, recognizing optimal times for statin discontinuation, and promptly identifying and treating SINAM. It also shows that while distinguishing between ASS and SINAM is crucial for comprehensive care and prognostic planning, it is important to consider overlapping conditions and atypical cases. It also highlights the ongoing need for further research to enhance diagnostic accuracy and improved patient outcomes in similarly intricate cases.